Thank you very much, Dr. Muhammad, and thank you all our speakers and guest personnel. Thank you, Dr. Hani and Dr. Bintani. This webinar is actually taking us into several aspects of the COVID-19 management, which is really difficult and it's different. It is variable. Still, we don't have any evidence-based that we can actually rely on. We will go on to hear another remarkable experience from the US, from Professor Dr. Adel Basili, who is the head of the Surgical Intensive Care Unit in Mount Sinai in New York. And we all know that today, New York has more than 300,000 cases of COVID and about more than 23,000 fatalities. So Dr. Adel actually will talk to us from inside the kitchen, what is happening and how can we elaborate on this. I'm also very pleased to welcome my co-host, Professor Dr. Walid Abdullah from Ain Shams University, and also Professor Sani from the University of South California. And we will start by Dr. Adel Basili, please.
Thank you, Dr. Adel.
We should start by Dr. Adel Basili. The organizing committee, we cannot hear Dr. Adel.
Dr. Adel, excuse me, we couldn't hear you. Is there a problem?
Basili
is muted. Still muted.
Yes. It's now.
Dr. Adel. Hello?
Hello, do you hear me?
Now, we hear you.
Oh,
Welcome.
great. Oh, thank you. I'm glad.
Okay.
Thank you, Dr. Adel, for this kind of introduction. It's really an honor and a privilege to be joining this team panel and faculty in this. I'm sorry? Do you still hear me?
Yes, it's good.
Sorry.
Okay.
It's a special place in my heart because I'm a graduate of the Ain Shams University. So it's really like coming home. I'm happy to share our experience at Mount Sinai in New York City. I've been privileged to work there for the last 19 years. This is the dashboard from Johns Hopkins and shows you the volume of the cases globally. About 3.3 million cases positive. And you can see on the top in the United States, it's about 1/3 of them in the US. And this 1 million, the majority are in New York City, in New York State.
Dr. Adel, can you please share with us your screen? It's not shared now.
Sorry. Okay. I apologize. I have it here.
Okay. Okay. Thank you.
Thank you. So we have the highest number of cases in the United States and obviously in the world as well. And in New York City, especially, it is the highest volume. So we're really in the epicenter of the COVID crisis. We were prepared. We knew we had to prepare quickly. And one of the credits I should give to our structure and organization and leadership. The first rule, there is no rule. We did things for the very first time and things unprecedented and unheard of. Anybody can do anything. We didn't worry about lawsuits, which is a big deal in the United States. We got a lot of people credentialed in less than 24 hours, something unheard of. Any documentation barrier were removed. We used things for the first time like anesthesia machine as ICU ventilators. We use even operating room theaters as ICU rooms for cardiac surgical patients. We used and we tested 1 ventilator and 2 patients, and we had some success in that. We also established a tent in Central Park, right across the street from Mount Sinai, and run by physicians from North Carolina and volunteers. We put 2 patients in 1 ICU room, which is another unheard of. A lot of things had to change. On the right, we converted, this is my surgical ICU in the middle. We converted each of the open rooms into closed room and negative pressure room and put a HIPAA filter connected to the outside. And this is how all the rooms looked from the street, from Madison Avenue. These are the anesthesia machine, converting one of the regular floors into ICU floor. And that's how we increase our ICU capacity. This is the lobby of Mount Sinai, and the makeshift beds were created for ICUs and piping some oxygen and suction and air to accommodate ventilations. Our usual day, we have 104 adult ICU beds. At one point, we were caring for close to 300 beds, or on the vent. We were preparing also for the worst. What if we get sick and we don't have enough? What can we do? We were preparing for tele ICU, so people who are convalescent at home and can work can round with non-intensivist and manage the crisis as well, has been used a few times. It is very different than our traditional ARDS. A lot of the speakers pointed out a lot of important differences. There is a big dissociation between the severity of the hypoxemia and the respiratory mechanics that cannot be explained. There are micro and macro thrombosis. We've seen micro thrombosis at autopsy reports and autopsy results, but we also see high incidence of deep vena thrombosis, as well as arterial. We had a patient last week with bilateral renal artery occlusion. And that's important because we need to look for these, not assume this is a septic acute kidney injury. Very high incidence of acute kidney injury, which we really underestimated based on what's reported in literature, about 5 to 10%. Our observation is way higher than that. We were surprised by seeing high incidence of delirium, recurrent fever of 41 and 42, which we coinciding with a dramatic drop in the blood pressure. And it's very interesting, as the patient cools down after we pour a lot of fluids in the patient and pressors, as the patient's temperature goes away, the patient magically gets off pressors, and then till the next episode, and happens again. So really amazing vasodilatory shock that we observe, and it is maybe an indicator of the cycle. If you look, you'll find the incidence of rhabdomyolysis. I think it's also underreported, and for some reason we had very high incidence of male patients compared to the female. I'm going to touch base quickly on some of these. The ventilation, it's really variable in these patients. Early on, the lung is compliant. Dr. Gattinoni shared his experience a couple of weeks ago in a paper that was published as a letter. And there are 2 phenotypes. The H phenotype, this is the classic high elastance and high right to left shunts with heavy lung and recruitability. And these are the classic low tidal volume strategy and high PEEP and proning that makes sense and improves. But early on, patient present with this type. You can see on the left, there is not a lot of fluid and there is not a lot of consolidation. And these patients don't get better with proning. But as the disease progresses, and it's a spectrum, and things get worse, there is a room for recruitment and use proning. Dr. Arbi was also co-author on the recommendation and the surviving sepsis campaign updates to adapt to the COVID pneumonia, and using conservative flow strategy is a standard of care. However, early on, we noticed that these patients, especially as I described, when they drop the blood pressure suddenly, and you realize your acute kidney injury is high, you wonder whether they need fluid or not. And we do a lot of echoes, and we see collapsibility of the IVC, and we see the echo, the ventricles are empty. So there is room to give them fluids and together with pressure, we see more response. They're not a cookie cutter. Not every patient is the same. You really have to customize your therapy based on what's going on, but use a lot of tools to see whether it's a pulse contour analysis, systolic pressure variation, or echocardiography, which really we used a lot, and we use it before the COVID, and we definitely use it more, especially try to minimize exposure of others. Proning, we really started doing proning early on, and 12 to 16 hours recommendation. We came up with a protocol for 16 hours. The operating rooms were closed because there's not a lot of surgeries. So we used some of the ward technicians, and we trained them on how to prone. And we create 24/7 proning team. We just announced we need to prone Mr. X in bed 5, and then 8 people show up, and they down and down, and they go in under supervision of the attending, and we monitor the process of the proning and see the results. And then when we put the patient back on supine, the same process, we announce this is the time for proning the patient. Interesting, there is a lot of data on proning awake patients and self-proning, which some people believe that it may prevent progression of the ARDS, to worsen ARDS. ECMO, and I want to thank Dr. Arabi for answering the question about ECMO. ECMO is in the algorithm when you have refractory hypoxemia and you are paralyzed the patient and you did proning at least 12 to 16 hours and the patient is still refractory. ECMO is in the algorithm. So when we anticipated we're gonna do a lot of ECMO, we have ECMO center, we have a transplant program. So we're very familiar with ECMO. We have 7 adult ICUs, and one of them is dedicated to invasive cardiac devices, including LVADs and ECMOs. So they were getting ready and they were prepared. They recruited about 20 ECMO circuits from the operating rooms, and we have the staff and we're ready to go. We have to have proning, one of the requirements. And today, the result is very disappointing. We ECMO'd 6 patients, 5 of them veno-venous, 1 went from veno-arterial into veno-venous, 3 died, 2 successfully decannulated, and 1 still on ECMO as of today. We have criteria that patients should have good prognosis, meaning not a lot of comorbid condition before this, apart from the severe hypoxemia. And a lot of young patients were candidates. But I think our results mirrors what the Chinese have reported also. This is from Wuhan, and you can see that about 50% survival as well. They out of 12, 5 died, 3 improved without ECMO, and 4 alive but with coma. So it does not come with without a price. Price and staffing, as Dr. Arabi mentioned, it's a resource intensive. Best outcome from literature we know in centers where they do it routinely. So this is not something that you should contemplate if you don't do it. And we were referral in a couple of areas around us, but a lot of the patients are really not good candidates and not have survival benefit before. So we end up doing very limited number of ECMO, and I shared with you our results so far. And this is 6 weeks into the epidemic. I mentioned the staggering amount of acute kidney injury. This is a summary from one of the websites of all the trials so far, mostly observational studies. But if you really look at the ICU level of patients, the incidence is somewhere between 19% and 39%. And my own experience is higher than that. Again, part of unprecedented time that we are living in. We were preparing ourselves for what if we ran out of ventilators, but also what if we ran out of dialysis machines and CVVH, and we almost got there. And we started doing things that we haven't done before, including peritoneal dialysis. And we're going to share our results. So for the first time in 20 years in my ICU, we did about 5 or 6 peritoneal dialysis patients, which is, again, unprecedented before. The neurological manifestation, this is a recently published article, try to describe the neurological manifestation in COVID patients, and a lot of them related to thrombosis, and whether it's micro or macro, definitely a higher rate of strokes. But it strikes me a higher rate of this executive syndrome, which is a new term also, which is inattention, disorientation, and really poorly organized movement to respond in response to commands. It struck me how many patients are severely delirious. And we typically see that in older populations when they get sick, and we use a lot of benzodiazepine, which we are avoiding. But it was surprising to us to see it in young patients, including I had pregnant patients who were only on propofol, and a week to 9 days on the ventilator. And when they get better, we get them extubated, and they're completely delirious and fit that description of this executive syndrome. And they take a long time to recover. And the older patients are, it takes much longer to improve. This is our protocol, how we go forward. And this is, again, changes. We keep changing, and everything we plan, we end up changing it again. And this is the most recent version of our protocol. We used to give hydroxychloroquine with azithromycin. We see more and more lack of efficacy and evidence that really makes a difference. We're waiting for more randomized study, but that was part of our protocol. We currently have these trials, remdesivir, convalescent plasma, mesenchymal stem cells, TOSI. We added another trial, which is gemcitabine. It's a monoclonal antibody that acts on granulocyte macrophage colony stimulating factors. We feel maybe this will have an effect. Quickly on remdesivir, based on observational study with improvement in about 68%. It was part of our protocol from the beginning. However, got restricted use, and we didn't have much access to it early on. We only had limited supply, so we use it on a compassionate basis, especially in pregnant patients. This is a letter of the FDA approving the use of remdesivir just yesterday. So we have the FDA approval as of yesterday. And what's interesting, it's based on a study, and this is a study that published in Lancet, and you see there is decrease in duration of mechanical ventilation. But this is not really the panacea. You need to get more information, and we're waiting for more details. Interestingly, it wasn't statistically significant, by the way, the improvement in the shortening of the ventilation time. But also the death rate was interestingly slightly higher, still not statistically significant in the treatment arm. I think we need to take everything cautiously, and this is one of the advice we try to remind ourselves, not just jump on the bandwagon and because somebody is doing and believes it works, that means that we should be doing it. The convalescent convalescent plasma program started early on as we start getting more patients, and as patients start to get better. We're the largest center now for plasma, and these are the criteria basically, and they were revised early on. The criteria: adult patient, positive for COVID, and have a life-threatening condition. And these are the parameters. We were avoiding at the beginning giving it to people who are in renal failure, not on dialysis, for fear of volume overload, and also not too far into the disease. And I think that's still the message here. Too far into the disease, we don't know whether this is helping or not. And we're seeing more observations of increasing the frequency of the cytokine storms. And we don't know if that really makes a difference or not. These are one of the tweaks that we were doing before. One, we're giving it within the first week of symptoms, and not really on advanced ARDS. And now we're extending it as we have more pool of patients, of donors, and more blood groups. Now, instead of expect the patient to have good probability of survival, we just need somebody that has a chance of survival for 48 hours. And instead of just within the first 7 days of symptoms, now we're expanding. We have enough from the blood bank, so we're giving for up to 21 days. I can't tell you the results because I don't know the details yet, but anecdotally, it's not the one that everybody believes it's going to save the patients. I think we need to wait to really analyze the data. Hemodynamics, critically important, how you monitor hemodynamics and how when the patient decompensates, what do you do? I mentioned we use a lot of bedside ultrasonography and echoes. The assumption is the patient goes into arrhythmia, can go into myocarditis from virus. We haven't seen that, and we analyze a lot of the arrhythmias that happens. We do see this typical arrhythmias from somebody who's in septic shock, typically atrial fibrillation, and we're monitoring also the QT prolongation, and we haven't seen as much, but we have seen a lot of thromboembolism, including PE, in an alarming rate, and that's what triggered us to create an anticoagulation algorithm, and we started that very early on. If patient is hospitalized, is automatically on anticoagulation protocol, therapeutic anticoagulation, not prophylactic. And if the patient not in ICU, we use apixaban, simple enough to give. It doesn't require much monitoring. If the patient gets to the ICU, then we use either low molecular weight heparin or unfractionated heparin, depending on the renal function, and obviously with proper monitoring for signs of bleeding as well as renal failure. And these are, since we started the protocol, we don't see as many cases, but the fact that we see arterial thrombosis makes us now thinking, should we consider antiplatelets in addition to the anticoagulation? Again, we don't have randomized controlled studies. More likely, we're going to rely on a lot of observation till we have that. Lastly, I want to share with you our tracheostomy data, which we are contemplating. We had over 600 patients on the ventilator in about 6 weeks. These patients, about mortality rate of the patient in general, about 30%. A lot of these patients, similar to Italy and the Lombardy region, when they reported, about 45% of the patients stay in the ICU even 4 weeks later. So these patients become chronically critically ill, and you need to manage them. And one of the question is, what do you do tracheostomy? And we really believe that we should not change the standard of care for these patients. So our recommendation is what we're doing before, between a week and 2 weeks. And our experience so far, in 1 month, we had dedicated our tracheostomy team to this task. Our tracheostomy team was functioning before. We have dedicated 10 surgeons who any ICU needs a tracheostomy, that would do it. And especially now, there's not a lot of operations happening. Even the intensivists in the group will get busy. So we end up relying on them, and that would go, one day they did 8 tracheostomy, another day 3 tracheostomies, and with proper PPE and infection control precautions. In 1 month, we did 111, 23 discharged alive, 2 of them home, and the remaining 21, and that's an important observation, is went to facilities that already started weaning, but they need longer time on weaning. So to create capacity, we're able to send them to weaning facilities. We also created a weaning area in our hospital where they can go. So we do have weaning floor dedicated for COVID patients. Our median time to tracheostomy is about 11 days. Some of these patients had repeat re-intubation, and that's the nature of this disease. Patient can get better and get worse again. You can't really predict who is going to improve. I hope this is helpful to you, and I'm happy to answer any question and share more of our experience.
Thank you very much, Dr. Adil, for this very encompassing illustration of your experience. We have lots of questions, and we need lots of time to go to Dr. Walid and Dr. Sani. However, I would just like to highlight for the ECMO patients, if you have the full resources and there is no issues in the logistics, would you go to a PF ratio of 100 or 150? Because the ELSO criteria still in written says it should be below 100. Although some of our colleagues who are working with the ECMO says it's much better to put the ECMO earlier in these patients, so you would just go to 150. What's your cutoff in Mount Sinai?
So we use a criteria for proning early on as well. So we started after for PF ratio less than 150. This will be an indication for proning, and if the patient fails proning and has a chance of survival, then will be an ECMO consult and consideration. So the patient needs to demonstrate failure to proning, and the cutoff for proning is 150. If the patient does not improve less than 150 and remain refractory after at least a day of proning, then there will be a consideration for the ECMO. And that's it's not a high criteria, not a high bar to achieve. Unfortunately, our experience is not encouraging, and I think there's a lot of anecdotes sharing similar results. Unlike the SARS, we learned from the Australians that were the first one to report a much better survival rate with ECMO during the SARS epidemic in 2004. We don't see that happening in COVID-19.
Okay, thank you very much. Dr. Ali, please.
Dr. Adel, for this nice presentation. I'd like to continue just after the question of Dr. Adel. When you say that the patient is refractory hypoxemia and the failure of proning after single trial or of 12 to 16 hours, or it should be repeated 2 or 3 times?
It's a good question. I don't know if we know the exact timing of trial of proning, but typically patients in this condition, when you prone, a lot of them, the oxygenation improves, and then you lose that effect till you turn them back to supine. So not just one time proning, usually more than 24 hours to see what happens to them, especially when you put them back supine. So more than 16 hours, usually this is the time when you should repeat the blood gas and see what's the gas exchange look like. Again, all that is just looking at numbers, but you need to look at the whole picture and what are the prognosis of the patient. We still felt that 6 of them meet this criteria and they still remain refractory, and despite that, half of them died. So a lot of people believe there's one therapy that's gonna save the day, whether it's a plasma, whether it's remdesivir, whether it's a COVID. I think the answer is more complex than that, and it's a syndrome like my colleagues mentioned, and Dr. Arabi and Dr. Bouchard as well. It's a syndrome, and I highly doubt there is one intervention is going to help. I think we need to look at all the supportive measures together. But the answer, when you start thinking about ECMO, you are desperate, and then you need to weigh in to dedicate these resources or not, and then have a good discussion with the family about what anticipated outcome.
Dr. Ray, please unmute. Yes.
Actually, Dr. Adel was as regards going to the ECMO, our colleagues who are used to perform be bad, and so I think as you said, it will be much more beneficial to go to the ECMO if indicated early in the course of the disease. Is it right, or we should try for more than a week?
I'm sorry, the sound was interrupted. Are you asking if you should skip proning and go straight to ECMO? Is that
No. I mean after some trial of proning, if the patient is not improved, we go to the ECMO, because after 1 week, our colleagues said all the time that it will be the outcome will not be favorable after 1 week.
1 week? You're asking if you should try ECMO for 1 week?
No,
and then
the first week.
Oh, you wait first week. The question is when this week starts, or whatever the timing start is. A lot of patients they present in different times through their illness. A lot of patients come already late, and they end up being intubated on the in the emergency room. And you question them when the symptoms start. They can tell you it could be 3 days, it could be 2 weeks already. So we don't know the timing of their decompensation. Another observation is a lot of these patients tolerate hypoxemia surprisingly to us. You see them, they're a little tachypnic, but you look at their blood gas, been hypoxemic for a while without even knowing, and they tell you, yeah, I've been breathing like this for many days. So 1 week from being on the ventilator versus 1 week of being presenting with shortness of breath, I really don't have an answer, because we don't have data to support one way or another.
Okay, one last question, please, as regards the convalescent plasma. What is the proper timing to give the convalescent plasma?
When we started, because we didn't have enough plasma to give, we were very cautious and we didn't know what to expect. So we started within the first week, as I mentioned. As the supply in the blood bank has increased, we start allowing more, and now up to 3 weeks after onset of symptoms. But you need to have somebody who's recovering, or has a good chance of recovery. I'm sorry, not to give late stage when somebody is multi-organ failure, or been on the ventilator for 3+ weeks and about to die, and then you're gonna now see what the plasma can do. Again, I want to caution you that a lot of people really believe that plasma works, but the reality, we don't know, and it may hurt patients. It may cause more cytokine release, which is something that we're observing. We have about 40 initial analysis. When we did, they had 40 patients received the convalescent plasma. 5 of them died. So it's not like we have a great solution here. And I think as we analyze more of our patients, we're gonna learn more. And the question is, who is the best candidate and when to give? That's still unknown.
Thank you, Dr. Basili. I would like to introduce Dr. Sani Jah. He has a very rich biography. Assistant Clinical Professor of Anesthesiology, University of Southern California. He's a Clinical Operation Director, LA Surgery Hospital for COVID-19 patients. He's a Board Director, American Society of Interventional Pain Physicians, and a Board of Directors, American Society of Pain and Neuroscience. He's also delegate in the American Medical Association and the American Society of Anesthesiologists. Welcome, Dr. Sani, and it will be nice to hear from you.
Thank you for the kind introduction, and thank you to the organizing committee. Can you guys hear me okay?
Yes, please. Welcome.
Thank you. Okay. Today I will be discussing novel therapies for COVID-19 patients here. And let me get to the top here. Okay. Screen's okay? Can you see the screen okay? Okay. So like was mentioned, I am also helping to record I'm helping also to run the Los Angeles Surge Hospital, which is a hospital that our state leased to help care for patients who are COVID positive in the event that the other hospitals in the Los Angeles area are overrun. So that was an amazing experience, and we are operational, and I was just working there overnight. So, okay. So this is just an X-ray from just last night. We had an admission come in, early active disease. Many of you have, I'm sure, seen this and understand what's happening with our disease here. So you see the bilateral pulmonary infiltrates, classic COVID-19 picture here. So in preparation for this talk, I knew there were a lot of therapies out there, but I didn't realize how many. So this photo is dated from April 13th, so a little over maybe 2-3 weeks ago. 160 plus drug and vaccine candidates in development. And they had a prior article to this in which they mentioned 60 drugs were and vaccine candidates were available. The initial article was dated early March. So as you can imagine, it's a very high interest area in healthcare and across many different areas. So I try to focus on some of the candidates that appear to be most promising, that appear to be the most well-known, and some of the other ones that may or may not be well-known, but do appear promising. So it's important to recognize that the NIH has no guidelines for treatment of this. No drug has been proven to be safe and effective for treating COVID. We need clinical trial data, and they're emphasizing infection prevention and supportive care at this time. Regarding antiretroviral therapies, hydroxychloroquine has meant there's no insufficient data to support its use. Remdesivir as well. There's been a lot of news on remdesivir this week. We'll kind of touch on that a little bit later, and the previous speaker touched on it as well. Also, hydroxychloroquine, azithromycin, lopinavir, ritonavir, and HIV protease. There's actually evidence to recommend against the use of it. So, interesting data. Immunomodulators as well. Convalescent plasma and hyperimmunoglobulin, also insufficient data as discussed earlier. Also with the interleukin-6 inhibitors, IL-1 inhibitors, insufficient data again, and there's actually data against interferons and JAK kinase because of their sledgehammer type effect to broad immune suppression. I saw this image in preparation for this talk, and I thought it kind of highlighted the ability for us to treat and our strategy for treatment. And unfortunately, I think we do have a problem with getting to treating this virus too late, and that we're in the stage 2, stage 3 treatment phase. That's when most of our treatment efforts are beginning, and our most heroic efforts are in the stage 2 and stage 3 phase, and where you have the pulmonary and hyperinflammation cytokine storm stage. So I think one hallmark of this talk will be the emphasis on getting patients in stage 1 or stage 2A and 2B as quickly as possible to try to stop you from entering the stage 3, where you have the cytokine storm and massive hyperinflammation inflammatory phase. Touched on this earlier, hydroxychloroquine. This is all basically news from this week that I'll be presenting over the past 2 weeks, essentially. New study, 90 patients. Hydroxychloroquine was associated with QTc prolongation. Those who took both azithro and hydroxychloroquine had a greater QT prolongation. Those who had pre-existing QT prolongation and those who were on loop diuretics also had more profound QT prolongation. And in this study of 90, actually, one of the patients got Torsades. And another MGH Harvard review this week, based on their clinical experiences as well as the review of the data, also showed as likely ineffective and actually cautioned its use because of the immunosuppressive nature of hydroxychloroquine as it's being used to be treated for patients for rheumatologic disease. So that could be problematic, as many have already discussed with the advent of this disease virus. Convalescent plasma, discussed by our friend from Mount Sinai. Again, there's subjective evidence on its being more effective if given earlier. Subjectively, people say they feel like it slows the progression of the disease and may in fact prevent an ICU admission. Another issue with the plasma is we simply just don't know how much antibody is actually making it into the patient. We don't necessarily quantify the amount of antibody in the plasma as it's extracted and given to the patient. So we're not even sure how much these patients are getting. So it might be a good idea to pool plasmas together, and that's a way to help reduce the inconsistencies in the amount of plasma antibodies being distributed. There's also approaches concerning monoclonal antibodies and also intravenous immunoglobulins, which again have not really shown much evidence of effectiveness yet. Remdesivir, a lot of trial data came out today, over the past Monday into Wednesday. The phase 3 study being led by Gilead, which is the drug manufacturer, they basically were comparing 5-day dosing or 10-day dosing of this virus. Folks who received the folks who received remdesivir early within 10 days of symptom onset appear to have better outcomes than those who received it later. And this kind of goes along with much of what's been an underlying theme in our treatment, is that we're probably getting to these patients far, far too late for any of our treatment modalities to be effective. Treatment with 5-day dosing versus 10-day dosing with very similar outcomes. Clinical improvement for folks who received the treatment was about 10 to 11 days, regardless of whether they got 5 or 10-day treatment. More than half the patients in both groups were discharged from the hospital day 14. That's 5-day treatment and 10-day treatment. 64.5% were discharged, and 53.8% at day 14 had clinical recovery. And 64 at day 14, 62% of patients who were treated early were symptom-free and discharged versus 49% who were treated late. So again, the idea of treating these patients early might be more effective. Also, there's an NIAID study of 1,063 patients who received remdesivir. 31% of them had a faster time to recovery than placebo. It was 11 days for remdesivir versus 15 days with placebo. Mortality rate was 8% versus 11.6% for placebo. So some data to suggest that this may help, but like the previous panelists mentioned, this is not a slam dunk by far. This is not the magic bullet everybody was hoping for, but when you extrapolate 8% or 1,063 patients to a much larger number, for example, such as what we're dealing with now with millions of folks infected, they can make a sizable impact. Suddenly 8% is a lot of people. So I think people kind of get carried away in the small statistical numbers, but that's a lot of people when you have a large problem like we do here. The Lancet study from China was actually terminated early because of slow enrollment due to the effectiveness of China in controlling this virus. So they felt there was not very much statistical benefit with this, and that they were not able to determine any difference in time to clinical improvement for those folks who received remdesivir versus placebo. Of the folks that actually got the treatment late, but they also did notice a numerically faster time to recovery for folks who received remdesivir early, as in less than 10 days. So there appears to be a window to give remdesivir where actually can be more effective, and that appears to be less than 10 days. And but like it's said, like we've been discussed all day today, a lot of these patients, they don't show up until 2 weeks into the disease course. So whether the drug maintains its effectiveness in a population such as that remains to be seen. Tocilizumab is the IL-6 inhibitor, which IL-6 was implicated as an upregulated inflammatory mediator for the cytokine storm. It was thought that if you attack IL-6, you can reduce the amount of inflammation and prevent worsening of the disease. Preliminary data showed some benefit, but however, it's important that before you use this drug, that neutropenia associated from it can cause exposure and risk to secondary infections. So when it's used stateside, we test patients for TB, hepatitis B, C before we even give the drug. There hasn't really been too much concrete data supporting its use. We've seen some patients improve, some patients not. So, but then again, we frankly just don't know very much about this disease, sadly. Sertolizumab, similar. Kevsara is what's the brand name. IL-6 and antibody as well. It lowered CRP in one study, but whether that was helpful remained to be seen. They had patients who received it who were in severe phases of this disease, which meant they required supplemental oxygen, and they had a separate arm of critical patients who were mechanically ventilated in the ICU. The patients who were severe tended to progress towards critical disease, but the patients who were critical had some benefits. So they are now proceeding with the phase 3 trial. There's actually a dose-dependent effect. So the 200 milligram dose was not as effective as the 400 milligram dose, it appears. And so the new trial is focusing on 400 milligrams among severe mechanically intubated ICU level patients. So it'll be interesting to see what exactly comes from that. This is a Japanese drug, Avigan, antiviral drug initially meant for influenza, also treated for Ebola. 340 patients in China had a shortening of the time after they were treated. They went clinically and virally negative from the treatment. The time to recovery was shortened to 4 days from 11 days. And radiographically, they had a dramatic improvement in chest X-ray findings. 91% of treated patients versus 62% of untreated patients as well. So further trials are underway on this as well. Japan seems to be thinking very strongly of this, and production based on their analysis, that's ongoing analysis, is increasing on the drug. So there may be some promise here. Vaccines, a lot of stuff out there. April 23rd, the WHO said there's 83 candidates, and 7 of which have been approved for human testing in clinical trials. One of them that appears to be the most further along is the Oxford study, 1,100 volunteer patients. They found that it was effective in 4 rhesus monkeys, and so they're going to move forward with phase 2 trials in human participants. They expect to have some results in the next 2 to 6 months. There's some microRNA-based vaccines. There's engineered antibodies. There's people trying to attack the spike proteins of the virus. A lot of very convoluted, very interesting strategies, but these are months to years away at best. So that's why I kind of glossed over this particular section. So ACEs and ARBs, there was some discussion regarding that because the ACE angiotensin receptor was associated with viral entry of this virus into the cell. And actually were associated, the use of ACEs and ARBs were associated with improved outcomes depending on how exactly you use the ACEs and ARBs. So if you have patients with a history of hypertension who are on ACEs and ARBs pre-exposure, they appear to have improved mortality rates in that 3.7 versus 9.8% of hypertensive who were on ACEs and ARBs prior to infection. People who took ACEs and ARBs 7 days before symptom onset had improved mortality in outcomes, 14 to 29%. So very interesting data there. Again, maybe this might be a preventative measure. Again, further studies need to be had to discern if there's any more statistical or clinical significant difference, or when the best time would be to use these drugs on patients. Among patients who were started on ACEs and ARBs in hospital who were COVID positive, there was no difference in severity or mortality of those patients. And then another study in New England Journal by a good friend of mine actually showed no harmful association of ACEs and ARBs with the use of in-hospital mortality. So yeah, sure, start it if you can. That's kind of the gist of ACEs and ARBs. Leronlimab, IgG4 monoclonal antibody. This is a very small study on this drug. They had 7 patients so far. I think all of them actually did dramatically better after receiving the drug. They had a reduction in inflammatory markers for cytokine storm. So this is a drug that is rapidly growing as far as their clinical trials and studies going on for this one. Lopinavir, in vitro studies showing some effectiveness, in vivo not really. A lot of underpowered studies as well, but I don't think there's really much more activity going to be happening with this drug. Alaris, another drug, phase 3, IL-1 blocker, is also in study, and Novartis is going to be leading the trial, and there's no real data from that just yet. Arbidol, another one, broad-spectrum antiviral targeting the spike glycoprotein. Again, clinical trials underway on this one, no real data just yet. This is another X-ray from today from a patient I took at the LA Sturge Hospital. Unfortunately, what happens when patients are treated too late, they enter the end-stage fibrotic stage of ARDS where the lungs are basically peak pressures of 49-55. This patient has severe subacute emphysema. I've never seen such profound. She probably has a pneumo somewhere in there, but she's too unstable to transport for CT scan. But severe subacute emphysema, likely from a pneumo somewhere, and peaks of 45 to 55. A lot of comorbidities, likely end stage and not going to make it. So it's important, I think, for us to begin to treat these patients early. Any questions?
Thank you very much, Dr. Sani, for this very elaborate illustration of several novel modalities for a really confusing disease. Actually, we are very late. However, we have two major burning questions from our attendees, and they ask about, for you, Dr. Sani and Dr. Adel, both of you, about your weaning method for these patients. When to start weaning, and what is the acceptable PF ratio that you extubate your patients upon, and do you use non-invasive ventilation immediately after extubation, or you just wean to a regular mask or a regular nasal cannula? Can you please elaborate on that?
Yeah, so for us at the LA Sturge Hospital, we're a transfer-only center, so every patient that comes in is transferred from other health centers in the LA area. So among our patients, we've successfully extubated, I think, 8 or 9 patients thus far. We've only treated about 50, and maybe of that, 20 of them were intubated there. But we do extubate straight to high flow nasal cannula. PF ratios, we do look at that. Certainly, we kind of accept lower PF ratios. I think a lot of it also depends on the sedation of the patient as well, and the strength of the patient, the length that they're intubated. So if you have a frail 60-year-old, 50-kilogram woman who has been ventilated for 3 weeks, that's somebody you want to make sure that they'll have the muscle strength to and the oral pharyngeal strength to clear the secretion. So we actually had to make some of our older, more frail patients because of the fact that they're so deconditioned from being intubated for 3-4 weeks in some cases. So we are finding that we have been able to intubate some patients that were, wrote off as lost causes. We had a patient I extubated maybe on Monday that, when they came to us, peak pressures were 45. And they dramatically improved. They somehow turned a corner and they magically improved. And this patient had all the obesity, diabetes, hypertension, male, over 50, dramatically improved within days. And we got him extubated, which, he beat all the odds. And so every case is very different. I don't think there's a one-size-fits-all for this disease. We're learning so much about it. And I think, I imagine something similar to
Yes,
Right.
I echo Dr. Jawad's sentiment about the criteria for extubation. Like any other disease, it's really it's a clinical decision, and it's a multifactorial decision, because these patients, we learn that they tend to decompensate, and they get better, and then decompensate and get better. A lot of our tracheostomy patients end up being previously extubated. I don't have the exact number right now, but that's a reflection of how they get better, and then you extubate them, and then they reintubate. There's no magic number for the PF ratio. It depends on what else is happening in the patient, whether encephalopathy is a factor, fluid overload, renal failure, and also the strength of the patient. And they really get weak very, very quickly, especially if they've been exposed to paralytics. Adds another layer of weakness, ICU-acquired weakness. It's not that simple of a decision. At the end, it is a clinical decision, and you try to use your best judgment whether this patient is you're gonna give a trial of extubation or not. But you have to also weigh in your ability of rescuing the patient and quickly don the PPE and be ready to re-intubate the patient. In terms of the protocol, the usual standard extubation protocol, we don't have preconceived extubation to non-invasive or high flow. Although we've tried high flow nasal cannula post extubation, and some do well, some don't. It's not that clear cut. Every case is different.
Another thing also is the sedation for these patients. A lot of these are prolonged mechanical ventilation with extremely high levels of sedation to prevent ventilator dysynchrony and further barotrauma. So weaning sedation patients can be quite challenging. So we frequently have been extubating patients on large amounts of sedation because then you kind of find this fine line between ventilator dysynchrony and barotrauma, and we're making them worse. So that's also been an issue as well.
That's actually another question that some of our attendees ask about. Do you use specific sedatives or analgesics in the COVID patients, or you just use any drug like Precedex or midazolam and so on?
We try to avoid using benzos, diazepine, some midazolam, but some patients, when you have ketamine going, propofol, Precedex, fentanyl, Dilaudid, everything, you don't have that many options left, and
yes,
do great with that. Midazolam. We typically try to avoid them. We've been having a lot of success with Precedex and just leaving the Precedex even post extubation for days, as kind of to help them with the withdrawing off of the ketamine and the products that many of these patients have been on for days. So we have a patient we extubated, I think 5 days ago, and still on Precedex because of their prone to having outbursts and their sundowning and their ICU delirium and the withdrawal from all the other medicines that they're on.
I agree. We as much as possible try to avoid the benzodiazepine, including the midazolam. We use a lot of Precedex, but we see that we reach to the maximum very quickly, and it's a very minimal effect. We end up treating patients with propofol, and our use of propofol has gone up. And we're concerned whether we can run into shortage of propofol. We fortunately did not reach that level, but we ran out of hydroxymorphone shortage, the Dilaudid, and that was interesting. We had to switch a lot of our patients. But again, these patients take long time to recover, and the cumulative effect of sedatives and analgesics are staggering. And we try to practice daily interruption of sedation, provided you can oxygenate them and ventilate them as much as possible. You won't do that to somebody on high FiO2, and you would have to come below 50% before you start thinking about doing that.
I think from our experience as well, a lot of times for patients that are on minimal vent settings, I mean, I basically have gone into a room and basically treated like an OR case where I'm weaning sedation and managing it like I'm about to extubate a post-op patient, or patient that's in the OR, because I don't think you can necessarily rely on the nurses and the respiratory therapists to handle these very complicated patients. So it does require a lot of human capital to do it right, especially with these very, very interesting patients where their critical care needs are just out of control. Very, very hard, very hard to manage these patients. They have to tail in disease.
Thank you. Yes, Dr. Walid, please.
Please, I have a sample questions just for you as regards interleukin-6 antagonists. Is it appropriate to measure the interleukin-6 level before giving the interleukin-6 antagonist, or it should be given by the time frame based on the clinical data of the patient? What do you think?
Yeah, we measure the IL-6 level before we give it, as well as in that same blood draw, we test the patient for TB, Hep B, Hep C, HIV, any sort of pathology that can cause an opportunistic infection down the line. It's also for academic purposes to see if there's any effect of the drug on the actual IL-6 levels. We do inflammatory markers. Some facilities here do a daily inflammatory markers, ferritin, LDH, ESR, fibrinogen, all those D-dimer, all those inflammatory markers. We do about 2 to 3 times a week, or if there's an acute change in the patient's clinical status. So we do measure the IL-6 prior to giving it, and IL-6 has been shown, elevated levels have been shown to been predictive for patients to enter or require mechanical ventilation.
Please, Dr. Basili and Dr. Jha, of course. What about adding ketofol, ketamine to the propofol in the sedation? We tried in a short number of patients, but it gave a little bit good results with hemodynamic stability.
Yeah, we use ketamine. Yeah, definitely. 20 milligrams an hour, sometimes even more. We had a guy who was. We had a patient, a 30-year-old man, who was on all kinds of drugs, marijuana, methamphetamine, all kinds of drugs pre-COVID, and I can't even remember how many. I think he was on 200 milligrams an hour at one point, 100 milligrams an hour, 150 milligrams of propofol, like 500 micrograms of fentanyl, and so he's obviously a very extreme case. But this is a guy we actually extubated awake on 100 milligrams of propofol and Precedex at 1.8. So I mean, every clinical situation is different, and it depends on the resources. If you're in a resource limited environment, like many possibly the hospitals in your areas, you have to use what you have access to. In my experience, internationally, drug efficacy and drug effectiveness is also comes into question. I've some international work in the Middle East, and we've had bupivacaine that doesn't work, and so I understand that you guys also suffer through that. So whatever you have access to, whatever works, just use it. I think
we use a lot of ketamine, and I feel sometimes we go into waves. We use propofol a lot one week, and then the next week we use a lot of benzos, and then we retract again. It depends on what's happening with the patient. Especially if they're getting paralyzed, this is the time that to say, okay, we're going to use benzodiazepines because they're going to be awake and how much they're going to feel. So it varies. There is no one drug that's going to work on everybody. That's what we learned. And also we learned that not the same drug going to have the same effect on the same patient throughout the course of the ICU stay. You're going to go into waves of working better today, working worse tomorrow.
One last thing, one last observation for Dr. Basili. I noticed and I am happy with the picture with your background of Tutankhamun and the book of Egypt, about Egypt.
Yes.
Yes, Dr. Basili is Egyptian.
Yes.
Of course. And from Ain Shams University, actually.
Yes.
So we thank Dr. Basili and Dr. Jar very much for their contribution of this very rich experience with the COVID patients. And we now go to Professor Dr. Hani for the conclusion of this webinar. Thank you very much.
I'm extremely happy to conclude this webinar. Hope it was beneficial for all of you as it was for me. Thanks for all guests from all over the world who gave us their time and experience, and that proves that we all are sailing the same boat. Attendees, you made our webinar very beneficial with your input, and I'm sure that guests will be more than happy to answer your questions at their convenience. Iris Company, I would like to thank you. You made it easily for us and to do, and for all of us have a safe, successful practice, and thank you very much. Thanks all.
Thank you very much.
Thank you. Thank you very much.
Thank you.
Thank you.
Congratulations.